Now we're going to do a lumbar spine objective exam. My name is Rob Shapiro, Director of Clinical Excellence for Professional Physical Therapy. So we're going to go into the goals of the objective exam. We identify red flags, which Jessica talked about before. That's important. We're going to confirm or refute a hypothesis formed during this objective exam. We're going to determine classifications, and specifically directional preference, mobility, stability, motor control. So the key part is when we do our objective exam, by the time we're done, we want to be able to figure out, is a person have directional preference, which we'll talk about? Is it a mobility problem or a stability motor control problem? And typically we like to go in that order. In preference, directional preference, we want to make sure that's cleared first, then mobility, and then stability. That's the perfect world, but in reality, patients don't follow the book. So they're going to have all combinations of that, but we want to be able to make sure we still have directional preference, have they centralized, mobility, then stability. Looked at it, the standing exam, we're going to have Joe come in, and we're going to look at stuff. We're going to look at gait as Joe comes. We're going to have him just walk back and forth, don't go very far, just kind of walk back and get a general sense, and come on back. So you want to see, you need a little bigger distance, and turn that way. And you want to look from that component, shirt off if you would. From that component, you want to see how smooth does he work, is he walking. And we look at posture. If we turn this way a little bit, look at, does he have any kind of called lateral shifts? So if Joe came in, his pelvis was shifted that direction, we would call it a right lateral shift, a left lateral shift. We want to determine, come back up, does he have smooth curves? Get an idea. And is he weight bearing evenly? Does he feel like he's kind of hanging out on one side versus the other side? And that's key during your evaluation. Next part, before we start doing the testing, we're going to ask Joe, tell me where your pain is. We're going to, painful area, tell me, do you have back pain, leg pain? What pain level, 0 out of 10? What's the type of pain? Sharp, dull, achy. We got this from the body chart. From there, any sensory changes, numbness, etc., tingling, and the area of sensory changes. So that's before we go through it. Now, if somebody has a directional preference, centralization is key. So the goal is somebody who has something that's peripheralized. Centralization is what we want to talk about. Centralization is a phenomena in which pain that's either emanating from the spine but might not be felt there is abolished in response to deliberate application of loading forces, and that's key. So here's a great slide that talks about how something centralizes. So the person that has pain goes all the way down their leg. I'm going to ask Joe, tell me what your most distal pain is. So he tells me it's in my calf. And as it gets better, as it starts to centralize, and we know it has a directional preference, as he does movements, which we'll talk about in a few minutes, as he continues to do it, that pain will start to come back to the spine. So I'll ask him, okay, we just did some motions, where's your pain now? He might say it's up into there, and that's good. We repeat those motions. And key is looking for it to centralize to the lower back, and that's very important. So criteria for centralization. So when somebody does a motion, in order to have a centralization component to it, as soon as they finish that motion, immediately the pain still stays away. Let's say they had pain down their leg, they do, let's say, extension. When they're done with that, immediately following that, the pain is gone, it stays gone. Also under loading, as he goes sit to stand, as he moves, it stays centralized. And the course of 24 hours. At 24 hours in a row, that pain has stayed centralized or gone. So if we look for it, when we first do an exam looking at somebody, we're going to do through an example. Have Joe, you're going to have him first go through flexion, extension, side bend, rotation. You're going to have him do one repetition. The key to that is to see how they're moving. So I say, okay, Joe, go down to touch your toes, slide down, look at that, come back up, and we'll talk about more specific what we're looking at. That's the first part. We'll do extension and side bending. Next, if he had radicular pain, I have him repeat it. And I say, okay, tell me where your most distal pain is now. Okay, it's in my calf. All right, so as you go forward, as you start to go forward, it's still in my calf, come back up, and I repeat it, it's still in my calf. That's not a directional preference. It's actually, it hasn't changed it, and it might be worse. What if I had him go backwards, and I put hands on your hips, thumbs backwards. He goes backwards, okay, come back up, and it's in my calf, it's a little bit now, it's behind my knee. Repeat that, keep repeating, go further, 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 get to end range, come back up. And as he tells me, every time he does it, the pain starts to get more and more to the central part of his back. And that's called directional preference. So if there's no radiating pain, so let's say Joe didn't have anything down his leg, no directional preference, that means he went through the motions and that pain didn't get any better, and it wasn't worse because of it. Then we start thinking, maybe he has more of a range of motion or mobility issue. So he's going to bend forward towards his toes. He has no pain in his leg. Oh, it hurts. That hurts in there. Come back up. How's the pain? It's nothing, no better, no worse. Try it a couple more times. Repeat it. How is it? Come back up. No better, no worse. So we want to determine if there's a true mobility problem, right? Pain at end range doesn't get better or worse with movement. So then we start to look at, how do we know if it's a mobility problem, if it's something short, a joint or a muscle, or really like inability or core activation issue. He has poor core control. He's trying to stabilize. So what we can do is to change the stability requirements, meaning we have him perform the same motion with gravity eliminated, so we could do it either on the table, I'll show you, or adding some core activation. So Joe goes forward and he says, oh, I have pain, I can go right to, that's it, that's all I can go, come back up. Then I can say, okay, let's add some core activation. So I can put this between his legs, gently put that in there, gently squeeze it together, give him some stability, and all of a sudden now we can touch his toes. Okay, come back up. So I know just by giving him some core stability, he was able to do that motion. So I'm going to focus more for this patient, more on a core stability type program. Again, when we know we have a core stability issue, we talked about we have mobility issues above and below, but the key for him causing his symptoms might be a core stability problem, and that's key to know in how we're going to treat our patients. So as we go through the exam, we determine if he's able to do it. We talked about mobility stability problem, and then we'll move on. So as we're doing a regular exam and we have no directional preference, we're going to go through the range of motion. So what's the criteria for normal flexion? So Joe goes to touch his toes again. What am I looking for? Criteria-wise, can they touch their toes, which is not always the most important. Can the sacrum go at least 70 degrees? Is the spinal curve normal? Come back up. Is it a quality of control? And can he get his pelvis backwards? There's a lot of different components to it, but in order to be considered normal, he has to have those parts of it. What if we do extension? So put your hands on your hips, and you're going to bend backwards. So the criteria for here, does the shoulder blade go past the ankle? Which it doesn't. Does his ASIS go past his toes? That's looking at the hip. Come back up. Looking at the quality of motion, is it nice and smooth? Or is there parts of the spine that aren't moving well? Okay, same thing we can look for side glides, side bending we'll do. So I'm going to side bend over to this direction. Come back up. Let's turn that way, whole body. As he side bends that way, he has some pain through it. We're looking at the quality of it. How far can he go down and come back up? And we can do the other side as well. How well does he do it? And look at the curve and the inability, the smoothness of the curve. Come back up. Okay, so what if we did, so we decided, again, not every part of the objective exam has to be done, it's based on our subjective. If he was a directional preference person and he was able to get centralization, our exam is basically, has to do a neurological to rule out any of the bad stuff, but we have an idea of where we're going. Let's say he didn't have directional preference, but I think it still might be a mobility problem. I could add in a quadrant test. So I could do, Joe, take your hand, reach behind your opposite knee, down and over, and have him go down. We could stabilize and push down to get some overpressure and come back up if need be. This is turn this way, turn your whole body this way, face that way. Put your feet a little bit apart, and you can have him just do a squat. How far can you squat down? Kind of a quick rule out. Look at quality, a little stiff, Joe. Look at the ankles, look at the hips, etc. Again, as we do it, we're standing. So our neurological exam, we could have him do 10 heel raises. Face me, face me. Let me hold on. Okay, going to go up on your heel raises. If you see it, sometimes you'll see people who will be all kinds of on and off, who maybe compensate. So I might have them do one-legged, pick this leg up a little bit. Now try it on this side. Can you do 10 good ones in a row? And the same thing the other side. And relax. Now, can you do heel walks? Can you have them, Joe, you're going to walk on your heels and see if they, again, an L4 problem, they're just going to flop down. Come on back. Good job. Okay, sitting exam. So we're going to have Joe sit in the table. And we can also, again, if we weren't sure about our quadrant, we could also check it in sitting. Because what happens here, sometimes we take out the lower extremities, and sometimes when people do that quadrant test, they're all over the place. So I could also do, I want you to, going to bend backwards, side bend, come towards me, and then rotate back. And we can do a little overpressure in that position, just to get them to a quadrant sitting. We also like to look at posture changes. If for some reason standing he was all tilted, but in sitting everything is symmetrical, we might start thinking there's something in the lower extremity loading that tissue going above. And I like to do rotation. Some people do it in standing. It's perfectly fine. A lot of times I'll do it in sitting because I think thoracolumbar rotation sitting, arms across your chest. Okay, Joe, I'm going to have you do is rotate your body to the right, towards me. Hit the end. How's that feel? And you can do overpressure into that position and range. Again, look at that quality. And usually rotation, a lot of the rotation comes from T12L1. L5S1 gets about 6 degrees, the rest above it, not so much. But T12L1 is going to get a lot of that rotation, so it's a good way to check it in this position. Okay, Joe, you're going to go into your back. Actually, no, we're not. We're going to do a sitting exam. Now, if we're going to do a slump test, so slump test is for neural sensitivities, right? We like to do it in sitting as well as lying down. Sitting loads the tissue a little bit more and give you a little different aspect of what's happening with the neural tissue. So the key to this, couple of parts, and again, you'll see it differently. The way I always liked it is hands behind your back. Relax them that way. Any symptoms with that at all? No. I'm going to make sure all the joints are cleared, so just kick your leg up. Just kick up gently, come back down. Okay, ankle up. So make sure they have range of motion in that tissue before you start to test it. What we could do is going to have them, any symptoms at rest? No. We're going to have you slouch. What I like to do is look forward still. Don't put anything on. Just slouch through here. I like to keep the sacrum. Want it to keep it, no, you're good. Stay down. The sacrum has to be perpendicular to the table to keep that specific motion. Have anything in that position. Okay? I have them come down. Keep that down. Anything there? Good. What I want you to do is, it could be an active or passive. A little different. People do it differently, but if you can do it actively, you can come in here. We're going to lift this leg up, bring your ankle up. Any symptoms with that? Let's say he has symptoms. I can say take your head up. And does that change your symptoms? Yes or no? If it changes it, then we think it's some type of neural tension. And we could do it the other way. We could actually bring the ankle down. So go up and down. And that's the basic. When we do the class itself, we'll go more specifically into the class. We'll go more specifically into how to sensitize it. Going to go into your back, Joe. So a straight leg raise, and that way a little bit more up the table. More. Okay, so the key is to doing, again, a neural straight leg raise, which we know is more of a neural test. When I go into this position, a lot of people will start in all kinds of positions. You want to be a little bit methodical in that position. Make sure the knee stays extended, come through, and again, we could go through the same thing. Make sure all the joints are moving correctly. We go through here, we make sure he stays in extension. We could sensitize it first if we want. We're not going to go over the specifics of it. As I bring my leg up, I'll make sure that we're not AB or adducted. I'll keep it there. I do just a little compression, just to give an awareness. And what I'm looking for as I go up, looking for a couple of things. Looking for when I first feel resistance, but as a neural test, I want to see, does that reproduce the same pain you're experiencing? So if I come up here and I do it early into that 40, 50 degree range, and oh, that's my pain, going to get more of a positive straight leg raise. If he's just tight, and we can go through the components of it, we'll get to 70 to 90, we're thinking more lumbar SI motion. So those are the keys for that component. Again, be very systematic in how you do it. Dermatomes we can go through. We got the nice little tissue. So we can do L1-2, which is going to be, if I came up here, it would be more in here. You can tell me if it's same or different. If I go side to side, same or different. This is your turn. Same or different? Same? Okay, we'll come up through here a little bit. L1, L2 is going to be, we'll do through this area. Again, we'll do it on the skin. L3, my more medial knee. Same or different? L4, there you go. L5 can be, we'll have the sock off, but it can be between the web space. And S1, we can go on the outside. Same or different. If you're not sure, one of the first things to go away when we lose sensation is vibration. If you have a vibration tool, you can actually put a turning fork, you could actually start that. That's the first thing to go away when you lose sensation. So myotomes, I like to do them supine, and the reason I think it's more controlled, and you'll see people do it in sitting, and that's fine. But I like the supine because I think it's a little bit more control. So L2, bring it up. Hip flexion, I'll make sure he's in that right position. And I'm doing it for strength and be a break test. So hold your leg right there, Joe. Don't let me pull it. Hold, hold, hold. Good. We could do quad. I kind of go like that. Okay. Kick your leg up. Come out a little bit. Come down just a little bit. Hold it there. Don't let me push down. Hold. Good. And we'll go up in here. I like to do it this way. Bring your ankle up. Hold it up there. And up and in a little bit. Hold it there. Don't let me push. Hold. Good. And the key to all these, we didn't do it here, is repeat it multiple times. If you just do it once, kind of let it go a little bit, and he goes down, that tells you it doesn't hold. But if I repeat it, and now I'm going to do it again, hold it, and it gets weaker. There you go, good following. It gets weaker each time. As I do it, weaker, 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 I'm thinking the acetylcholine's not getting back into the synapse. So there's not a lot of fluid, axonal fluid getting down to the muscle. Give you an idea. So you can use it objectively later on. As you do it, you might even say to yourself, if fatigued after 3 or 4, now as through treatment, it's maybe 1 or 2, 5 or 6, 7 or 8, etc. So we did anterior tib is L4. L5, bring your big toe up, hold it up there, hold, 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 hold. And some people, peronei are either way. Some people say L5 or S1. That's fine. Push your ankle out, hold it, hold it, hold it, and good. Same thing in this position. You could do reflexes. Put my leg up there, and we're going to have to hold it there. He's dead. There you go. So we could do L3. We could do posterior tib. It's kind of a weird one. You can go on the bottom of the foot. You can get a little bit of posterior tib. Or you can get Achilles. Some people will do it this way. They'll go this way. Some people will do it up into this direction. Bring it up a little bit, and they'll hit it through there to get the foot to move, to get pressure through the Achilles to get that reflex. And then if we had to, again, objective, we're giving everything, but we don't always have to do everything. So if we thought it was an upper motor neuron lesion in our red flags lecture, we might do a clonus. The key to clonus is come up and give it a quick, okay? If you have 1 beat, when you start seeing 4 or 5 beats and you think upper motor neuron lesion, you start to kind of, you want to keep an eye on that and count the beats. So you push up and do a quick thrust. And you can do Babinski. You could use your finger. You could use this type of thing. So you're going to go lateral to medial. Okay, and normal reflex would be downward, upward would be, if it was abnormal, you would have the toe and then the other toes flail out. Okay, again, not every patient you're going to have to do it on. If you decided it wasn't a directional preference, they had no pain below the buttock, let's say, then that's the one that's the important part. Okay, so the next part of the exam we're going to go through in this position is we could also do, let's rule out some hip. Okay, so for hip we can go out, we can go up, we can do flexion, rotation. Internal rotation is the first thing that gets limited when we start to do, we start to get some arthritic hip, see if it causes the pain, but internal rotation is that first thing. Then we can do a quadrant test if we want. We can come up and in on the table, come up over, get them in there. We can do a little bit of a scouring. So I'm doing a little bit of a A to P motion and see if it has it for that. Okay, just to kind of rule out those components of it. Okay, the next part is going to go on your stomach. And if we need to, again, this is the same patient. We could put, you can go to sleep for a while. So this is the same patient, but maybe this might not have to do a femoral nerve test. That's L2 to L4. If it didn't follow your subjective, there's no reason to go do a femoral nerve test unless it fits in anterior thigh pain, L2 to 4 symptoms. First thing you do with a femoral nerve is any symptoms lying there, Joe? No, good. Anything in the front of the thigh. I hold there. I have them flex up. Somebody with it, well, 80 to 100. If they have a femoral nerve that's irritated, we'll get it 80 to 100. They'll feel it. If you're not sure, you could also sensitize it. I can go to that position. I could tell them to look up or down. Look up towards the ceiling. Come back in the middle. Look down towards your, we can sensitize it that way. We could add components through the leg. You can relax. You could add in, if you needed to, a little bit more sensitizing that with hip extension, those type of things. Be complete, S1 we kind of did in standing, but we could also do it down here. We can do gastroc or hamstring. The key with hamstring, the hardest thing is that people get cramps all the time. So I tend to push on the hamstring, give it a little bit of a break. Hold your leg there, Joe. Come down a little bit. Just in that mid-range, hold it there, maintain. Good, and then glute maximus. So if what I do, I'll have them do is put my hands on your butt, Joe, and what you do is squeeze your tush muscles and hold it there and see if they can push your hand away. And in this position, you could also do an ankle jerk if you wanted to. It's the same, you can confirm what you did before. Palpation, we're going to do a lot more when we do the live classes. Some of the things that people have a little difficulty sometimes finding. So one of the ways that people talk about, which is not always my favorite, but iliac crest go across, you'll be at L4-5. They take reliability because people, what if he has a big high iliac crest? One of the other ways is we can do PSIS and we can go 45 degrees down, probably a little more accurate. One of the key things, and we'll do it when we do PAs, is that when people do find L5 and they try to do PAs, we'll talk about, they tend to push straight down. For L5 is on an angle. If you remember the anatomy part, L5 is, so I'm pushing to get to L5 spinous process. I'm going down towards the pube a little bit. If I go like this way, it's L4, but if I go this way, I'm more to L5. And again, when we do the live classes, we'll definitely spend a lot of time on that. We can do passive accessory, so central PA. So the reason there's a lot of research, do we do PAs or not? One of the thoughts is that we do it for, a lot of times it'll reproduce the pain, so the patient's issue, and that's kind of a nice way for you to tell it's on the right tissue, for the patient to understand that, hey, I got the right tissue. So sometimes, again, the PAs are, I was going to go L5, I'm pushing towards the pube, take up the slack, and see what that spring is like. Take it off. L4, that's a central PA. Unilateral PA, if I want to get on the facet, interspinous, go right over, and I'll be where the facets would be. And then we'll talk more if we think it's more of an SI pathology, which we'll talk about in a few minutes. We could also just we could push on the ilium itself. Can it anteriorly rotate? We could do it on the other side. Can it posteriorly rotate? Can the sacrum, whatever words we use, nutate or counter-nutate? So this is the time just to get a sense of it. Again, you'll do more of this when your subjective exam told you to aim towards that and you ruled out directional preference, etc. So what about stability test? Again, if we needed to do it, you're going to come way over to the edge, Joe. Legs are way over the edge, Joe. So let's say we wonder if it's more way over, feet on the ground. Is it a stability problem? Okay, we come in, Joe has pain through here, and I push on L5. Oh, that's my same pain. Have him lift his legs just a little bit, both legs a little bit, hold on to the table, lift legs just a little bit. Don't have to go that high. And then if I go, you're off, yeah, and I push down, all of a sudden it went away. That's one of the prone instability tests. Another one I like even better, I think it has a little bit more, come back up. Sensitivity is, they read about, is the prone lumbar extension test. Again, know who your patient is. It might not be, has to be the right patient to do this exam on, but what I'll do is I'll straighten the legs out, little extension, and I'll just lift his legs, relax, tighten up a little bit. That's it, and we lift up his legs like that. And to the right patient, it gives you some more detail, some more data. Okay, we could do sideline face me. Again, this is the right patient, mobility person. We want to see what's going on. We're going to be able to we could do mobility testing, passer intervertebral testing. So come closer to me. I use the 1/3 rule. I like them 1/3 there, 1/3 in the middle, a little bit 1/3 towards me, a little bit closer. Knees are just off the edge, so these are off there. I'm going to palpate. I'm going to grab that, and I want you to do what makes a little sense is that people sometimes just don't get in enough. What you do is think about taking your hips and kind of pushing them in a little bit. That gives them a little compression to your finger, and then you could do your motions. So I can do flexion extension like this, okay, or that's flexion, or I can do extension where I take everything and I move everything back as a unit. Okay, we can also do rotation. Again, we'll do this more when we do the live classes. Come through here, I can get each level. I could just do rotation. The key is I'm using my body. I'm not just doing this, but I'm actually rotating my body to get some rotation through there. Some rotation. Okay, so you want to be able to feel that mobility-wise. You could also do is translation. Another way for, sometimes they'll say discal side, some gliding between joints. You can come up, find that neutral position, take your pelvis through there, hold, and then you could do a A to P glide, and just feel for that mobility or lack of mobility. It's a nice way to kind of guide you into which tissue to look for. Stiff? Okay. Sleeping? Okay. So other tests on your back. Now we did directional preference, we did more of a mobility person. What if they're a stability person, someone who needs core strength? We can even test more by doing some abdominal strength. So one of the ways I don't like the sit-up tests the way they're typically, well, I learned it in school. I like this, bring your legs up. Okay, come through here. Okay, she's about 80 degrees, arms are down, consistent, everything's consistent, palms up. Okay, hold that position. I'm gonna let go first, maintain it, and hold it. 1, 2, 3. What I'll typically do, that was good. What I'll typically do is I'll start really light. Sometimes just letting go, they can't even find it. They can't find that motor control. Start to give it light resistance, and then more, a little bit trouble as we start to push more on it. Come back down. Okay, go onto your belly. So what about, we talked about, Heidzen group talked about how the multifidi kind of opt out when we don't, after an injury, the multifidi tends to just shut right off. So what can we do to test it? Again, if we went PSIS on both sides, L3, we make a triangle, That's really where you can really palpate. That's the only thing that's muscle-wise is multifidi. Outside longissimus, thoracolumbar fascia, but multifidi get real close, really close to that spinous process. And then what I want you to do, Joe, is take this arm, put it up there, come back down, start down, relax. Okay, I want you to do is start to lift your right arm up. As soon as it does it, it kicks right in, right? And come back down. How about the other side? Switch arms. Yeah. Okay, and try to unweight. A little bit slower, but it came on this side. Come back down. There's your back pain side, huh? So he has a little bit slower of the multifidi kicking in. You start to feel it. All of a sudden, it takes a few seconds and it kicks in. And all of a sudden, his longissimus comes in. And so for Joe, we'd have to figure out, you know, we would he got lost based on what we just saw before, a little bit mobility through that lumbar. We'd work on that first. Then we've got to get those multifidi to kick back in. We'll talk about management in a few minutes. Okay, SI clusters. You can go on your back if you like. We're not going to go through them, but there's 6 tests that they do for SI. So again, we went through everything. We decided that how is likelihood of SI issue with this person? We did some stuff, which we'll do in a few minutes. Localization, we decided yes or no, maybe SI. Directional preference, some mobility stuff. But we do 6 tests. Laslett did distraction. He did sacral thrust, thigh thrust, Ganslin's, which are 2, and then compression test. So the quick versions of it, we're not going to do a lot of it. We can go here and here. We can do a distraction test. We push across, take up the slack, and kind of give a quick push on a little bit to see if he gets the same symptoms. We can do a thigh thrust where you come across, bring this up. And you'll see it different ways. I like to bring it up again. Come a little closer to me. Okay. Now come across here like that. Come up a little bit, and then come through here, and then give him a quick at end range to see if he has that. Gainslin's is more of like a Thomas type stretch, so come closer to me. Put this leg over the edge. Bring this knee to your chest. You want to make sure that he's there, it's good, there, and you look on this test. I want to be able to push each direction, see if we can hold it. Does that cause that same pain on both sides? Then go on your side face that way. Then we can do a compression test. Comfort's important. Okay, so we'll have him in a neutral position. We'll have him here. We'll come down right behind ASIS. We come down, we load it, and we can do a little bit of a thrust on it. And we'll see if it causes the pain. Muscle length on your back, just to be complete. Again, we most likely wouldn't do most of these on the first, but only as needed. So some people will do hamstring. I like it both legs up. I'll do it that way, keep the spine in neutral. What you do, Joe, is kick up we'll do the outside leg, kick up this leg towards the ceiling, come back down. And we compare side to side. It should get almost 78 degrees, 10 to 20 degrees of it. Stay in that position, come back down. And then last will be a Thomas test. Come way to the edge, which you've done over and over. Just gonna make sure we clean it up. So come all the way down, stand. Well, I always start with somebody with their tush on the edge, so they wind up being in the right position. We're going to bring this knee up towards your chest if you can. Good. And I'm going to help them back. I'm going to go on your back. Okay. So the key is a lot of people, I think, go too far with this. This should be in neutral to the back, just flattens. And you want to see what happens through here. Right? Does he have it? What happens when I straighten his leg out? Straighten your leg out. Does it go down a little bit versus the knee bent? So rectus. Right, iliacus with the leg straight. We can also do it, what if he was out here? We can come in, bend your knee. What if he was out here, and then we come across, and then he can't hold it down, and we're thinking more IT band. All right, good. Help him back up. Okay, putting it all together, thank you. We want to determine from our objective exam, is this our patient? Is this somebody who needs to be given to a specialist that's not our patient? What treatment categories does the patient best fit in? Everybody's not going to fit nicely into each, but there's some. We always know we want to start thinking this overlapping of each phase. Remember the treatment overlap progression, but I like to do directional preference. That's the first, mobility, and then stability. And all these patients will be a combination of each, but if you prioritize, I think you'll see good results with that. Okay, thank you.